Dr. Suzanne Goodman serves as training director for the UCSF Bigsby Beyond the Pill program, a program which promotes access and equity in contraceptive healthcare and builds a research foundation to transform clinical care. She is also curriculum director of the TEACH program, which provides reproductive health curriculum, training, and advocacy for residency programs. We are so excited to have you here today, Dr. Goodman. Thank you so much. And we'll just do questions in chat. There are going to be a couple times where Dr. Goodman's going to ask for you to either put in chat or to kind of unmute and speak. And so she'll kind of take the lead with that. All right. Thank you, Dr. Goodman.
Wonderful. Thank you so much, Shannon. It's really great to be part of this illustrious conference. And yeah, like I said, I'm happy to be joining you all from a non-icy part of the country. Yeah, I'm going to be talking today actually about innovations in contraceptive provision during COVID-19 with findings from providers in the US, but I'm also going to do two other things during this talk. One is to present a little bit of early data from a mental health study we did of providers. And for all the clinicians in this audience, I am also going to touch a little bit on what are some of the best practices that we're recommending for contraceptive provision during COVID-19. So there will be material on innovations, challenges and innovations, material on mental health issues that have come up for providers and that have been reported by providers. And lastly, a little bit on best practices. I wanted to just start by thanking my collaborators, Allison Comfort, Lavanya Rao, Tina Rain Bennett, Angela Barney, and Cynthia Harper, both from Beyond the Pill and also from Kaiser Permanente Research. Let's see. So a little bit of background to start with. Access to contraceptive services has really been challenging during COVID-19. There's been limited research looking at how providers have adapted contraceptive provision to continue offering these services during the pandemic. And also, just not too much. There's been a lot of conversation about innovations, but not too much really on that documented in the literature. So we conducted a survey among reproductive health providers reaching underserved populations in the US to do a couple of different things. One was to assess challenges in contraceptive service provision, to understand whether providers have adopted innovative service delivery approaches, particularly telehealth, curbside contraceptive services, mail order pharmacies, and specific changes such as the implementation of sub-Q depot, which I'll be talking quite a bit more about. And we'll also present early results that we did on a study we did on stress, anxiety, and depression among outpatient providers during COVID. And as I mentioned, lastly, we'll talk about best practices. In terms of methods of the primary study I'm talking about challenges and innovations, our survey reached 907 providers through April 10th of 2020 through the end of January 2021. Our sample reached 43 US states, Washington, DC, and also 3 US territories. I'll show you a map in a moment. Providers that we reached were also in different types of practice settings, and these included primary care clinics, health departments, youth clinics, hospital settings, family planning clinics, and abortion health centers. And we collected data on a variety of different things, whether or not clinics stayed open, the challenges that they were experiencing seeing new patients, and particularly in terms of offering contraceptive counseling and providing the full range of methods. Also, we wanted to understand the challenges that they had in meeting the needs of underserved patient populations, and if so, which populations were they really having a hard time seeing. And then also as I mentioned, the use of some of the innovations that we know about, including telehealth, mail order, curbside, and self-administration of methods. Our analysis was guided by the following conceptual framework that I think will help you understand the results a little bit better. During the pandemic, clinics varied in terms of whether or not they were able to remain open on site or whether they needed to close because of the pandemic. In turn, this may have led to increased challenges in seeing new patients and offering contraceptive counseling or the full range of methods, and to meeting the needs of underserved patients. As a result, these clinics may have undertaken innovations, but at the same time, we wanted to acknowledge the effects may be occurring in the opposite direction. In other words, clinics may have needed to close their on-site services, and as a result, they adopted different innovations, such as telehealth visits. The adoptions of these innovations may have in turn affected whether they faced increasing challenges offering counseling. So it could kind of go in both different directions. And we wanted to make sure our analyses would help acknowledge that. So we did, in terms of the statistical analysis, we did a multivariate regression analysis using generalized linear model adjusting for region, for patient volume, and practice setting. And I just mentioned that in part because one of the things that these generalized linear model adjustments allow for example, is it allows for clustering where you have different clinics, for example, so that you're not weighted too much based on having everybody say over in one clinic and then a few people in another clinic. So we adjusted for region, patient volume, and practice setting, and we were assessing the following things. So association between clinic status, specifically open on-site versus closed, and adoption of innovative service delivery approaches like telehealth. And then also association between adoption of innovative service delivery and challenges in offering contraceptive services and meeting the needs of underserved populations. This is the map of all of our sites. So we had participants from 43 states and Washington, D.C., and then the 3 territories included Puerto Rico, Guam, and Northern Mariana Islands, where we have done trainings or had participants participate in trainings. I think the Guam, and we did a big set of trainings in Northern Mariana Islands, and I think participants from Guam came for that. As I mentioned, we surveyed over 900 providers in total. So in the first, what I want to bring your attention to first is clinic status and what happened. So in the first bar, you can see the results for the entire sample, and then I'll break it down a little by specific clinic type. So what you can see is that most clinics remained open during the pandemic. So 81% of clinics continued to provide services on site during the pandemic. So that includes both the yellow and green portions of that top bar. 63% provided both on-site services as well as telehealth. I think that's the green bar. Almost 20% were closed on site, but still provided services through telehealth. And only 2% were completely closed during the pandemic, meaning that they were not open on site, nor did they provide telehealth services. Then you can start to see the variation in clinic status by practice setting. So for example, in primary care and public health departments, which is the second row, a much higher proportion of clinics were open and offering telehealth services. And for example, in abortion health centers, they were much more likely not to offer telehealth services, i.e. they were open but without telehealth services. This next slide looks at changes in contraceptive provision. And overall, 76% of providers reported that contraceptive patient load had decreased during the pandemic. And here you can see the breakdown a bit by practice type. I guess I'll just bring your attention to the fact that there were pretty significant differences with, again, the largest sort of continuation of patient contraceptive services was in youth clinics, school-based health centers, and colleges. And the lowest during this time was in abortion health centers. Then looking at reported challenges in providing these services. What you can see is that in our study, COVID-19 pandemic made it more difficult to offer contraceptive counseling. Overall, that was reported by 61% of providers. And then offering the full range of contraceptive methods was reported in about 66% of providers. Seeing new patients was reported by as being a challenge was reported by 83% of providers, and meeting the needs of adolescent patients in terms of contraception was reported by, again, a higher amount, about 85% of providers. And I'm not sure, but some of you may have been in on the presentation of particularly adolescent patients and what they were reporting. And we haven't yet had a chance to put those two surveys side by side to see how well they match up. In terms of COVID-19, in terms of the who did providers report it was harder to care for in terms of the patients they were seeing. So among patients experiencing poor mental health, this was reported as a challenge by a little over half of providers. Among those patients experiencing intimate partner violence, that challenge was reported by 46% of providers. About 44% of providers suggested that it was challenging to provide services for patients who wanted to prevent pregnancy overall. 36% of providers reported a challenge serving or getting contraceptive services to patients who were experiencing forced sex. And again, about half of providers mentioned that it was a challenge for those that were experiencing unprotected sex. Our data also showed that COVID-19 reportedly made it harder to care for patients who were low income. This was reported by about 40%. Experiencing homelessness, that was a challenge, reported by about 35%. Patients who were Black, Indigenous, and people of color was reported by a little over 30%. Undocumented patients was reported by a little over 30%. And patients who were geographically isolated or living in rural areas, again, this was reported by almost 35%. So all of these obstacles were reported by between 30 to 40% of our providers. In terms of contraceptive care innovations during the COVID pandemic, telehealth was widely accepted by contraceptive providers and reported by almost 80% of the providers that we spoke with. This was followed in terms of innovations by increased use of mail order pharmacies, which was reported by a little less than half of that, so about 35%. By offering curbside contraceptive services, this was reported by about 22%, and prescribing sub-Q depot for self-administration, which was reported by 10% of our providers. This is a complex slide, and I don't want you to have to break it all out, but if you want to look for the type of clinic perhaps that you work in, you can get a little bit of a sense of what was going on. So the first column of each of the larger columns in gray are the totals again. Telehealth was widely adopted, again, about 8%. But you can see that it was adopted by about 88% of youth clinics, school-based health centers, and colleges. Other innovations I've mentioned included offering mail order pharmacies. While this was 35% overall, it was provided by or reported among 38% of providers working at youth clinics, school-based health centers, and colleges. And then curbside contraceptives or services reported by about 20% overall, but 38% of family planning clinics. So you can see that was an innovation that family planning clinics really focused on. And then in terms of providing subcute depot, which again, I'll talk more about as we get later in the presentation. This form was used in 10% overall, but reported by 17% of family planning and abortion healthcare centers. This is just a detail on subcute depot, which is a form of depot delivery that you will see is being associated with high levels of satisfaction and a little bit more patient autonomy. And prior to the pandemic, it was reported by 4% of our providers. And then during the pandemic, it was reported by 10%. You can just see a significant increase. So when we get into the multivariate analysis, what you can see, and I'll just bring your attention to the fact that we're looking at adjusted relative risks. So when you see something that is over 1, that is a positive association. When you see something less than 1, that is a negative association. And I'll try and help with the interpretation of that. As someone who's a clinician myself, that I find that helpful. And then the stars represent the levels of significance that you can see. I think that's mentioned down. Let's see if that's mentioned down below. So clinics that were closed on site were more likely to offer telehealth, which the adjusted relative risk was 1.2, so a bit higher. More likely to use mail order pharmacies with an adjusted relative risk of 1.7, and much more likely to prescribe subQ depot with an adjusted relative risk of 4.4. However, at the same time, the clinics on site were also slightly more likely to find it difficult to see new patients, to offer contraceptive counseling, and to offer the full range of methods. So just as a reminder, in this set of analyses, when you see a coefficient an adjusted coefficient that is less than 1, it means that it is less difficult. This is one of the things that we're trying to figure out how to best present. So what we were looking at is, for clinics that were remaining on site, did they face less difficulty in offering the full range of methods? And if they did, it meant that they were either also offering, I'm going to read that one more time. Clinics remaining open on site faced less difficulty in offering the full range of methods if they also were offering telehealth visits, providing curbside contraceptive services, using mail order pharmacies, or prescribing subQ depot. And I just want to acknowledge that one of the conversations we're having as a team about how to present this was sort of how the question was asked, but for presenting the data, it creates a little bit of a double negative. And I recognize that. And I understand that it's a little hard to get one's head around it. But anyhow, we're kind of talking about the best way to write it up, and making sure that it also is legitimate based on the way that the question was asked. So the take-home points from this part of the presentation are that clinics that closed on-site services found it more challenging to offer contraceptive services, including contraceptive counseling and the full range of contraceptive methods. Secondly, clinics that were closed were also more likely to adopt innovative service delivery approaches, such as telehealth or curbside contraceptive services, and also subQ depot. However, it was clinics that were able to both stay open on site and offer innovative service delivery approaches that faced the least challenges in offering contraceptive services. I just want to, in our discussion, note that these results were somewhat similar to two other studies that were recently presented at Society for Family Planning. Society of Family Planning. One was a national study of office-based OBGYNs and by Kaiser Family Foundation, and another was a small qualitative study of providers in 3 states of reproductive health providers. And I won't get into all the details of those studies, but I'll just say that they also had somewhat similar findings to ours. So I want to stop for a second. I have 2 other big parts of the presentation, but I just wanted to stop for a moment and see if any of you had questions or comments based on what you've seen in your regions or in your own sites. And I thought I would ask you all a question as well to just see if there are any specific challenges in care delivery that you've experienced, or any innovations that we haven't touched on that you think might be helpful for us to add into our queries or questions that we're asking providers. And I know it takes a little bit of time to have these questions appear. So we'll just take a moment. You can also stop and take a sip of your tea. And I'll give them maybe a minute or so. I'll also just comment that I found it for myself really sort of intriguing. As I mentioned earlier today, we presented some of our adolescent data, and I'm finding that it's very interesting, but we haven't really had a chance to look at the 2 studies side by side. What are patients experiencing versus what are providers reporting, and how those correlate with each other. And then I also think that it was just interesting that 3/4 of providers were reporting decreased, patient load for patients seeking contraception. And I'm just very curious in terms of patients, where are they going? Are they just not getting as much contraception? And are we seeing kind of a similar increase in the number of pregnancies that people are continuing on, to term? So I think those are all pieces of the large picture that I'm looking for, but I don't know them yet. All right, I don't see any questions, so I think I'm going to go on, and we can come back if people do have more questions as they come in. So the second part of this of our data that I wanted to present, and we've done a poster presentation or a conference presentation on this. This was a study that looked at stress, anxiety, and depression among outpatient providers during COVID. And this was a qualitative study that was trying to address this notion that existing research primarily had focused on mental health consequences of the pandemic among inpatient providers and emergency room providers. But at least when we started the study, there was no existing data on outpatient providers and their experience during the pandemic. I'll just say that my own projected perspective was that I thought outpatient providers were just really potentially happy to be working. And that was a very simplified perspective and not necessarily what we found. So we conducted a qualitative study among outpatient providers to explore how COVID-19 had impacted their mental health. And in doing this, we undertook a content analysis of free text responses where providers described if and how the pandemic had increased feelings of stress, anxiety, and/or depression. Providers included physicians, nurses, social workers, and healthcare professionals across practice settings. This was a smaller study because it took place over an earlier portion of the pandemic. So it reached providers from 24 states with 288 providers participating. And it was data collected from mid-April to mid to late June of 2020. And it was, this is a study that's currently in Press and Reproductive Health and will be available soon. So a summary of our findings, and I'm not going into too much detail, but I wanted to give you kind of the broad brushes, and also to present some of the qualitative responses or quotes that people presented. So 2/3 of providers reported increased stress related to care provision during COVID-19. 1/3 of providers reported increased anxiety or depression related to care provision. And the primary sources of stress and anxiety and or depression were from the perception of the quality of care that providers were able to offer, changing work responsibilities, and lack of personal protective equipment. Also worry about the infection for themselves, and also worry about infecting family members. Also, it was really common for people to report work and home related concerns, such as either unemployment or I would say overemployment, including childcare. And then also fear of the unknown. Providers attributed their feelings of stress, anxiety, and or depression to feeling overwhelmed, being unable to focus, particularly working from home, lack of sleep, and worrying in general, worrying about the unknown. So I wanted to read some of the most notable quotes that came from our qualitative data. In regard to quality of patient care, a clinic manager from a family planning clinic in Tennessee said, "I hate for a client to not know if they can come see us or call us. We are here for them still." In regards to changes towards COVID-related care, an RN in a family planning clinic in Louisiana said, "The majority of our staff are assisting at the COVID drive-through testing center, but weekly we're testing approximately 300 people in a 4-hour span. It is hot and we are worn out." And then in reference to anxiety about COVID-19 among clinic staff, a clinic manager at a primary care clinic in New Mexico said, "The responsibility to present a calm and supportive environment to both patients and staff causes a repression of your own stress. This is exhausting. I had depleted my emotional reserves, calming others." In regard to worry about infection, a counselor at a family planning in Pennsylvania said, "I'm always wondering if this is the day I'm going to get the virus." And then in reference to concerns about home responsibilities, a family physician said, in California said, "I'm home all the time, working full time and homeschooling 3 children." And this was really remarkable to me, and one of the things that I want to look at more, because in family planning settings, a lot of our providers are women or identify as women and may have those roles. And I just think that we know that at least from the news, is that there's been a lot of attention to the fact that employed women in this country have really borne a lot of the responsibility of both work and childcare, and have also also had to accept unemployment more frequently. And then in terms of provider burnout, there are a couple of great quotes. One from an RN in Tennessee saying, "I can't explain it. It's horrible." And then another NP in a school-based health center in Oregon saying, "Feeling overwhelmed, stressed, unsure of what's right or wrong, don't want to come to work, I'm feeling down, and I don't feel like I have the support I need." So the implications of all of this are not only our frontline health workers being adversely impacted by the pandemic, but these findings really highlight the negative mental health consequences of the pandemic, even among outpatient providers, not just ER or hospital-based workers. And that the effect on personal health of these providers is significant, but also that they perceive that there's also a concern for the quality of care that they're able to offer. And I suspect that's because they're adapting to all these new changes and uncertainty in, I think even though there's strong evidence for what we're doing around COVID, those recommendations continue to change on a very frequent basis. And also the impacts of initiating telehealth and knowing, how is it reaching patients? Are we doing a good job? All these, I think so many new protocols that we're utilizing, as I'll mention in a few minutes. In another example of new areas of protocols have included syndromic approach to STIs as one sort of example where I think just there's uncertainty associated with it. So this study really also just brings attention to the need for policies to reduce stigma associated with seeking mental health services and providing increased access to counseling, treatment, and psychosocial support for providers. So once again, I'm just going to stop, and I have a couple questions for you. And also I want to welcome questions that you might have so far in the presentation. So I think for me, I think I mentioned that I thought that providers, I speak for myself just to say that I for one have felt grateful to be working, and I work both in outpatient settings and I also work in an ER environment. And we've had a lot of stress associated with electronic health records and bringing together telehealth and trying to take on the new challenges of telehealth. And as the study mentions, are we doing a good job? Some of those questions. But I think I was unprepared for some of the levels of stress that we were seeing. I had seen the immediate stress of some of my ER colleagues who were working. I'm not working in a high volume COVID center. We have most of our screening in another environment. And I've really seen the stress of people working really directly with COVID, particularly in the inpatient setting. Just that notion of like, how can I not get COVID was very prominent for people. So I did not really expect to see this much stress in outpatient settings. And I think I just want to take a moment to like recognize that and recognize the work that most of you are doing, and just sort of throw some light onto that. Just looking here for a moment. The quotes from clinic staff and providers are powerful. Yeah, I agree. And I just, sometimes quotes, and it almost makes me want to do a qualitative study where we are able to put video clips together of some of these staff reading their own, or speaking to their own challenges. I feel like that would be extremely powerful and an interesting way to sort of incorporate our move toward the virtual world, is just to be able to express that. So I think I'll move on. Again, I continue to invite any thoughts, but I'm going to go ahead and move on. And this is material. I just wanted to leave you with some of the practical tips that we are recommending when we're doing our contraceptive trainings for providers these days, because we also really wanted to be able to sort of give people some clarity about some of the best ways to provide contraception during this time period. So first, just a little bit of background. So to accommodate the need for social distancing with COVID-19, I think, as you all know, federal privacy regulations were relaxed and payment policies were expanded to cover a variety of telehealth services. This happened with Department of Health and Human Services, Office for Civil Rights, and Centers for Medicaid and Medicare. And just bring our attention to telehealth as a way to simultaneously allow for social distancing, maintain essential health services, but also really to help uphold autonomy. And, I think that I just want to recognize that both contraception and abortion care are still seen as essential services during the pandemic. And I think this took a little while and has taken clinics a little while to find the balance with, because at first, there was that whole period where they had to stop seeing patients and then developed their safety protocols and then figure out which patients they could see via telehealth. What could they do just based on telephone, and what did they really need patients to come in for? So a few things about telehealth. It really helps to allow for social distancing, to reduce exposures, to preserve staff availability and PPE for the highest level of priority visits, and then also to provide access for many reproductive health services without a clinic visit. So these included patient-centered counseling, as well as method initiation for all of our hormonal methods, barrier methods, or it could often be done for self-administered methods as well. And then also continuation and method switching. And I wanted to show you sort of a sample family planning triage template. So there are many ways that clinics could triage clinic visits, and these often are changing week to week as counties are going through their variations in what's happening with the pandemic. And prioritization has to be fluid depending on changing physical distancing laws, staff capacity, PPE, and pickup circumstances as well. And clinics have revised policies frequently based on these, both changing policies and what their individual circumstances were. And all of the things that I've bolded are things most specifically related to contraceptive provision. But I as I mentioned earlier, syndromic treatment of STIs and UTIs was something that many clinics were starting to do, either through virtual audio or audiovisual, and also managing bothersome vaginal bleeding and pelvic pain, such as PID or IUD complications. Those were sometimes things that could be screened for and then provide same-day service for. So you'll see we put these into postpone, things that can be done by telephone, things that require virtual audiovisual contact, things that hopefully are done in person, but as appointments are available, and then in person same day. And I'd like to mention that this as soon as possible column are things that we want to be thinking of these as urgent visits anyway. And so if your clinics are not doing these things because you don't either have that provider on site that day, or because they're not things that you're doing yet in your clinics, they're really good things to be thinking about in terms of helping with rapid access referral. So for example, a patient calls in, they want emergency contraception. They've had, I'll go through these examples in a moment, but they have reasons for which EC pills are not going to be as effective. So you might want to take the time, for example, to help them figure out where they can get another appointment quickly for some of those visits. So in terms of minimizing exposure for in-person visits, there are lots of different recommendations, and this will probably be a review for most of you. So a lot of the intake and counseling and at least the pre-consent, if not the actual consent, can occur doing phone or telehealth. One example of an innovation in one of the family planning clinics that I work in is they also separated if they couldn't get the consent prior to the patient's visit, they would have the patient sit in one room and have the staff sit in another room, and they would talk with each other such that they were just in different spaces for doing the consent. And then symptom screening can happen prior to arrival. Obviously, that's specifically for COVID symptoms. So delaying symptomatic patients who had fever, chills, cough, shortness of breath, sore throat, lack of smell or taste, etc. Also, we're recommending that patients either bring their own mask or have a mask provided. A lot more, depending on the clinic site, a lot more patient waiting is happening in cars or outside of the clinic. And that was always a lot harder in urban clinics where people were coming in via public transportation, and also in colder climates that could be a little bit harder. Another sort of way to innovate in-person visits to minimize exposure included minimizing room changes, so having the patient stay in one room and having the staff sort of cycle through that room. And then also monitoring PPE to be sure you knew what was going to be happening sort of next, by the end of week or next week. In terms of pivoting our services, some of the really significant changes have occurred by minimizing contact with patients and also minimizing unnecessary testing or doing testing in different ways. So for example, whenever possible, if you can't provide a method today, initiating a bridging method as needed. Secondly, doing lab tests by self-swab or as needed. Thirdly, assessing pregnancy using history elements that are described in the CDC's selective practice recommendations, or confirming pregnancy by LMP and then possibly using a home urine pregnancy test. Another way to minimize contact has to do with how do we get blood pressures. So you could look back at recent blood pressures, or either in the last year or even in the last 3 to 5 years. You could have the patient check a blood pressure at home or in a pharmacy. And then sending prescriptions to pharmacies, or shipping medications or pre-packing medications for curbside pickup. And then, as I mentioned earlier, delaying visits for people who have COVID symptoms or contacts or are pending test results. In terms of contraceptive provision itself, I just want to mention sort of what we're recommending for the various methods. So for combined hormonal methods, pill, patch, and ring, pretty much everyone, if that's a new patient, can get a 3-month supply pending a blood pressure check if you don't have access to them having a blood pressure. Those who have a history of hypertension, you might want to start them on a different method, or make sure that their blood pressure gets controlled before you started them on a combined hormonal method. And then if they have no high blood pressure in the last 3 to 5 years, and you have a blood pressure either that they can give you or that's documented in the chart, and no history of hypertension, then you can go ahead and give them a 12-month supply. In terms of depot or DMPA, it's for IM injection. It tends to require an in-person visit that can be done in your clinic or in the pharmacy. Although I do bring attention for patients who might have learned to do IM injections. Let's say some patients who are, for example, are patients who are on testosterone. They might already have that skill, or also for patients who might have a healthcare provider at home who can do an IM injection. That's also fine. And then I'm going to be talking in a second about sub-Q depot for self-administration and what the studies show about that and how it's done. And then IUD and implant, both for placement and removal, tend to require an in-person visit, but not necessarily for IUD removal. So I'm going to talk about that as well. So for placements, initiating a bridging method as needed. And then, as I mentioned earlier, you can do the education, consent, and payment via telehealth. And we advise also for all of these, not for all of these methods, for some of these methods, we also advise evidence-based extended use for all patients who want it during COVID. And I would say this is a recommendation we have anyway. The next slide really shows what those durations are. So for those of you who might not be familiar with this concept, most long-acting methods, especially IUDs and implants, have longer evidence-based durations of actions than the original FDA-approved durations that are noted on the package inserts. And this is because data continues to accumulate after FDA approval, and it's very pricey and labor intensive for companies to replace the patient labeling. So I often like to point out that our patient labeling is the least evidence-based materials that we can share with our patients. They're really not very up to date. Although some of the companies have made some efforts in this area. So for example, Paragard, I believe, was initially FDA approved for 8 years, then it was extended to 10 years. There's very strong evidence of its duration for 12 years and some early evidence that it actually may be good for 15 to 20 years. So that's data that will be coming out in the future. For our 52 milligram IUDs, they're both now FDA approved for 6 years, but can be there's strong evidence for 7 years. Kylena and Skyla don't have evidence-based longer durations at this point. And Depo, as you can see, has slightly increased durations. And I think you're familiar with this in reference to like how long can a patient wait before they come in for their next shot. And I think just recognizing, especially during COVID, that it's hard to get these additional visits for removals, that we want to be thinking about these evidence-based durations. I'd like to point out that this is also, for all of our trainings, this is really also one of the reasons that we recommend the medical leadership come to our trainings, because updating protocols is also a really helpful part of what we innovate through our trainings. So I'm going to also touch briefly on self-removal. And this is something that has gotten a lot more attention in the literature in the last 5 years. And I think that it's an area of clinical care that I used to shy away from a little bit, even with the first data looking at whether or not patients were actually, it was kind of a feasibility study that was presented. So the feasibility study had some really interesting information. One is that it's safe for patients to remove, but the feasibility study showed us that it has a very positive impact on patient autonomy. So in specific, the thing that was remarkable to me about that study, that was Diana Green Foster's study, and it showed that particularly BIPOC patients and patients of color suggested that more of them would be interested in the IUD as a method, but also that more of them would recommend it to friends. And that was really stunning to me and really just reflected back, I think, what we already know, which is that those are patients that have a different experience of healthcare and contraceptive counseling and may more strongly value methods that they can control when to stop and when to start. That study also showed that 1 in 5 people who were interested in self-removal were actually successful, and that there were certain predictors of self-removal. And those included a slightly longer string length. So instead of the 2 to 3 centimeters, more like 3 to 4 centimeters. When I counsel patients, I'm now doing 4 centimeters, and I just say to patients, I give them this string to feel. I say, you can check it if you find it reassuring for yourself. You don't need to check it every month after your cycle. That's old information. This is what it'll feel like. It softens up with time. And if you want to self-remove, that's something that is safe to try. So I've gotten more comfortable, and I've gotten more comfortable specifically because of the studies of another primary care provider by the name of Dr. Jen Amico, who had she had studies both of providers and patients that described how mixed the feelings of providers are about self-removal. And I think that's natural, because I think providers sort of want to do that clinical counseling around whether or not, is there anything else we can try? I think one of the things that Jen Amica's studies also showed were that a lot of patients, a large proportion of patients, had really significant delays getting an IUD removed that they really wanted to have removed. So one of the things we're emphasizing in our counseling around this is that there's a lot higher satisfaction if you spend more time up front talking about bleeding pattern changes. And two is that we talk about removal when a client wants to have removal, and we initiate that visit with saying that, yes, we can remove it today if you really want. And also to start by saying, this is, oh gosh, that must be so hard, or something that reflects back to them that you're hearing them and that it's common, and then see if they're open to having a clinical conversation about alternatives. Sub-Q depot. Let's spend a little time on sub-Q depot. So this is a delivery form that may improve continuation and access and autonomy. And it's it's different than the IM form. I'll be showing you why it's different. But sub-Q users found in different studies, I think we have 3 randomized trials and 3 controlled cohort studies that looked at self-administered sub-Q depot compared to in-clinic IM depot. And they 97% of participants found that sub-Q depot self-administration was very or somewhat easy, and 87% would recommend it to a friend. The 1-year continuation rates in the one of the randomized trials within Planned Parenthood found that it was improved by about 15% at 1 year. And among the clinic group, over half reported interest in self-administration in the future. Satisfaction was similar between the groups, and also, although that there was also some increased site reactions in the sub-Q group. It does take a little time to teach and to learn how to do sub-Q. This can be done virtually. There are some online videos that teach it, but it also can usually require some kind of a virtual visit. And it may be available in pharmacies. Some states a TAR is required, but that's also been an area for advocacy where work between physicians and involved pharmacists has been helpful. So this image shows the injection sites. So it's the anterior abdomen and the anterior thigh, which, as you can imagine, are easier for patients to reach. And also they're slightly fattier areas, particularly the abdomen. So you're not going right into muscle. So how does sub-Q depot differ from IM? So for one, it's self-administered into easier sites. It uses a shorter, smaller gauge needle. It has a smaller volume to inject. It's about 2/3 the volume. It's potentially less painful. It has about 30% less hormones. So there's some early questions about whether it may reduce side effects. I think we're still waiting for more data on that. But as I mentioned, it takes time to teach and to learn, and it may still require a TAR. This just shows you that comparison in a little more detail. So the different size needle, the slightly lower dosing, the slightly different packaging. Of note in regard to the packaging, I believe that both are temperature stable, so they don't need to be refrigerated and can be sent out by mail. And the satisfaction with both is quite high and similar. I want to also briefly touch on emergency contraception, and particularly what can be done remotely versus what requires an in-person visit. So of note, the copper IUD is probably what we have the longest duration of evidence on for emergency contraception. And it has evidence that goes back to the mid-70s, but has always been used off-label. A more recent and really hot off the press non-inferiority study looked at the efficacy of levonorgestrel 52 milligram IUDs. So that's Mirena and Linoletta. And it shows essentially that it is non-inferior to copper IUD, that almost 100% of patients did not have an ongoing pregnancy. And this was a very robust study that seemed to have, of note, about half of its patients with a BMI over 25, which you will see is very important when it comes to the efficacy of emergency contraceptive pills. And about 27% of its patients had a BMI greater than 30, so in the obese range. So over 25 is overweight range, and over 30 is the obese range. And its use may increase the number of patients initiating highly effective methods, with one study showing that 2/3 of patients that were interested in IUD as emergency contraception were interested or preferred the use of levonorgestrel IUD for ongoing contraception compared to copper IUD. And we also know that the continuation rates are quite high for patients who want IUD for emergency contraception. I believe around 65 to 70% in the different studies. And then the emergency contraceptive pills, the one that's been around for longest is levonorgestrel, or Plan B. That is the type that was approved in 1999, and then Plan B one step was approved over the counter in 2013. And then the FDA approved Ella, or ulipristal acetate, in 2010. And the next slide goes over a little bit of the evidence around weight and emergency contraception. So what we know is that as you go into the overweight range, so over a BMI of 25, first the levonorgestrel emergency contraceptive pills lose their efficacy. And they also lose their efficacy as you go from 3 to 5 days after unprotected sex. And they also lose their efficacy as you go from one episode of unprotected intercourse to multiple episodes of unprotected intercourse. Also, Ella, or ulipristal efficacy, falls off as you go into the overweight BMI range, which is over 30. And during sort of throughout all of those ranges, IUD efficacy remains essentially 100%. And that compares to an overall EC pill efficacy of about 85%. So that's really important to keep in mind, but particularly for those patients who aren't great candidates for emergency contraceptive pills. So in conclusion, and I'm just going to kind of wrap up for the entire presentation, clinics that closed, so from our first study, clinics that closed on site found it more challenging to offer contraceptive services, including contraceptive counseling, and including offering the full range of methods. Secondly, clinics that were closed were also more likely to adopt innovative service delivery approaches like telehealth, curbside contraceptive services, in addition to sub-Q depot. And then it was clinics that were able to do both, staying open with on-site and also offering these innovative delivery approaches that face the least challenges in offering contraceptive services. From our second study, you could see that there are negative mental health consequences of COVID-19, even among outpatient providers. This came as a significant surprise to me personally, and a perception that COVID was affecting the overall quality of care that they were able to provide. And lastly, that there are many suggestions that we have for streamlining contraceptive care, for minimizing contact and testing during COVID-19, to continue to offer contraception as an essential service within healthcare. So with that, I again want to see if you have any questions about these innovative techniques that clinics are offering, or any other experiences that you've had during COVID, either personally or in your clinic environments, that you would like to bring to this conversation.